Assalamu alaikum wa rahmatullahi wa barakatuh. Very good morning, brothers and sisters. Let us start our session by citation al-Muqtab. Bismillah. اللهم انت ربي لا اله الا انت خلقتني وانا عبدك وانا على عهدك وعهدك واستطعت اعوذ بك من شر ما صنعت ابوء لك بنعمتك علي وابوء بذنبي فاغفر لي فانه لا يغفر الذنوب الا انت. Inshallah, today we will discuss about the dyslipidemia pharmacotherapeutics. Hopefully, last week you have some introduction and atherosclerosis and all this aspect. I will just maybe highlight few of them that quite related to the recommendation or the guidelines after this one. We'll try our best to focus mainly on the therapeutics and recommendations part. Brother and sister and MS team, are you with us? Can you hear me?
Yes, doctor.
Yes, sir.
Alhamdulillah. So hopefully, inshallah, we will able to get some refresher introduction about the dyslipidemia. Then straightforward, inshallah, we'll discuss further on the guidelines, the recommendations, and the management in a special population. The management in a special population. So, can you take this one to just make sure that everyone is have been wake up already, not just sleepy? How many of us attending today? 107, right? Inshallah. So the number should be here, 107. Here the question is asking about what is the primary target for dyslipidemia treatment. Of course, the abbreviation you're aware of, right? You already take atherosclerosis, the clinical biochemistry. So you know LDL, VLDL, triglyceride, HDL, right? Right? Okay. So what is the primary target? Primary target means mainly the treatment, when prescribed the treatment, we aim and monitor the level of this parameter, mainly. This doesn't mean the other parameters are not important, but we mean planning the treatment or planning the monitoring of any treatment later on will be based in the first place on this parameter, okay? Faster, brother and sister. 33. Still long way to go. Sometimes some of us are very conservative. They wait and see where the maybe the most people answering what LDL. Okay, so go for LDL. Okay, I will skip this one because we have another one inshallah later on. So the introduction, just a refresher for your mind. When we talk about maybe the lipids, cholesterol, triglycerides, and phospholipids, the most important for us, they combine with the proteins and form the lipoproteins that we are talking about. This lipoprotein have so many classes. The three major classes of lipoprotein that of interest when it comes to pharmacotherapy will be the LDL, LDLC, low density lipoprotein cholesterol, high density lipoprotein cholesterol, and very low density, the VLDL. Okay? The VLDL is the primary target for triglyceride in the circulation. So the levels, the correlation between the levels of the VLDL and triglyceride is very important. We have also intermediate density lipoprotein, the IDL, something in between the VLDL and the LDL. The lipid abnormalities in general of interest when it comes to cardiovascular disease, mainly because it quite strongly associated with the risk of cardiovascular disease, the coronary, the cerebrovascular, the peripheral artery disease. All these have been shown to be closely correlated with the lipids abnormalities. Okay, this is quite significant there. The group of the cardiovascular disease or the vascular disease that can be affected directly by dyslipidemia, we call atherosclerotic cardiovascular disease. Also, the term you should be aware following the atherosclerosis discussion earlier on. When it comes to the therapy, in the first place, we have to stratify the cases, the patients, based on the risk of the ASCVD, the atherosclerotic cardiovascular disease. So basically, our understanding now, dyslipidemia, to give treatment, is based on the risk. Risk of what? Risk of atherosclerotic cardiovascular disease for this case. This actually quite maybe straightforward calculations based on maybe quite number of tools. Just put in the patient particulars, the age, the comorbid conditions, the current assessment of the lipid panel in general. This one will be calculated. I give you one link already in the slides. So in general, when we talk about the lipid parameters, we will be very interested to maybe monitor or look the LDL level. So in general, we can say the primary target for the dyslipidemia treatment will be based in the first place on the LDL level. There is some exception, yes, but this is a general rule, LDL, yes. Some exception we'll discuss also later on. So as I mentioned, the main interest in dyslipidemia when it comes to cardiovascular disease, it is a leading cause. It is one of the major risk factors for people to develop cardiovascular disease is a dyslipidemia. Among maybe dyslipidemia is one, hypertension, diabetes, smoking, and others. But this one of the leading and major maybe cause of cardiovascular disease. The challenge is more when it comes to people when take the treatment, not all of them will achieve the target. This additional challenge. It is not about only giving the treatment, it's about achieving the clinical outcome or achieving the target you are aiming to. So one of the challenges in hyperlipidemia or dyslipidemia treatment, that when you give treatment, not all the people will be achieving and maintained on the target level. We discussed about this one. And those patients who have already cardiovascular disease are about 1/3 or less can achieve and maintain the target level. This also may be an additional challenge. You can see here, brother and sister, some of the data from maybe the National Health and Morbidity Survey in Malaysia, when they quantify the prevalence of the major risk factor over year, you can see maybe the hypercholesterolemia or hyperlipidemia in general is increasing trend. The prevalence 20, 35, now 47 is increasing trend. Also, this one from the same survey, when it comes some more data or statistics on how the challenge of hypercholesterolemia at the national level. Okay. So dyslipidemia, as all of us know, it is a well-established cardiovascular risk factor characterized, or we see in numbers, as total cholesterol more than 5.2, HDL less than 1 or 1.2 based on male or females, triglyceride more than 1.7, LDL, it depends because we see this primary target based on the risk. We'll see some details about this one later on. So the most important about the dyslipidemia is the screening. And actually, most of the people will have some kind of dyslipidemia, but they don't know. They just, for the random screening, they get to know that they have dyslipidemia. Especially dyslipidemia doesn't have maybe acute signs and symptoms to be there. Okay? Patient with dyslipidemia, for example, will not leave headache. For example, the high PP will not feel maybe dizzy or something like maybe abnormal glycemic level. So dyslipidemia can be there. The people live with, they don't know. So screening is very important. Screening, fasting or not fasting, it is not maybe a big issue because maybe the difference between both is very minimal and doesn't affect actually the cardiovascular risk estimation. LDL is usually can be calculated by so many ways, but maybe straightforward equation-based one, the Fried-Wald equation can be used for the LDL calculations. Okay. As I mentioned, the lipoproteins have so many maybe subtypes. I believe all of us maybe already have this background. But the most important, the term I want you to be aware of, the non-HDL. Non-HDL actually refers to the group of the lipoprotein have atherogenic nature, means they're more prone to cause atherosclerosis because not all the lipoprotein will cause the atherogenic one, the atherogenic possibility or potentiality. This will be having more maybe risk or contribution to atherosclerosis treatment. When we talk about maybe non-HDL, we talk about all this group, except, of course, you can see alone here, the HDL. Actually, this one will be very interested when we assess or the screen or further investigate dyslipidemia in patients relatively they have high triglycerides and they have maybe some kind of obesity and uncontrolled diabetes and maybe sometimes those patients have very low LDL level. We have also, I think, maybe in biochemistry, you get the apolipoprotein, right? The apolipoproteins, all the subtypes, everything. This one also, just maybe for points, very brief, the apolipoproteins, the APP analysis is very important in this category of patients when it comes to those patients with high triglycerides, DM, obesity, those metabolic syndrome, and maybe having all this and the LDL still maybe it is not abnormal. In those category of patients, the primary target can be alternatively goes for the non-HDL calculations and the ApoP maybe analysis, the apolipoproteins in general. So the apolipoproteins will be more credible assessment of dyslipidemia status in this group of patients. Okay, this usually the very minimal cases where the primary target can be something not the LDL. So in this case, when we compare about the non-HDL and apolipoprotein analysis, both of them can be used, and this one actually will be more accurate, will give us maybe more accurate reflections on the lipid of the risk, actually, the cardiovascular risk in this group of patients. This group, very specific. We talk about this group, not in general, okay? In general, we already maybe discussed the LDL is the main. Okay, brother and sister? You can follow? MS team, you can follow?
Yes, doctor.
Subtypes of dyslipidemia, sometimes this is the clinical one. This hypertriglyceridemia, many patients or some kind of patients can have maybe the LDL is not that elevated and the triglyceride is elevated. This one have a special maybe risk factor and a special treatment to be considered later on. Usually the triglycerides need to be very high to be targeted by treatment. We'll discuss this one later on. But just in some cases, if borderline high, but there is quite number of the risk factors, like maybe congenital heart disease, the family history of premature coronary heart disease, concomitant LDL elevation at the same time, the same assessment, the low HDL, the genetic form of hypertriglyceridemia, all this risk factor warrants maybe some intervention to be done for the triglycerides at this level. The low HDL, I think maybe the HDL, by our basic understanding, this quite maybe beneficial lipoprotein that increasing level confer protection against cardiovascular disease, increasing level. Quite maybe cases when we see this very low HDL can be seen in patients struggling with the insulin sensitivity. They have insulin resistance, they have physical inactivity, diabetes, cigarette smoking, high carbohydrate intake, and all this, and some medication, of course. The last one clinically will be the diabetic dyslipidemia. This is very common in patients with diabetes. They have maybe kind of lipid abnormalities, most likely will be presented as high triglycerides, low HDL, and elevation in the LDL. Okay, will be different in case by case, but in general, people with diabetes very prone to have dyslipidemia, and most likely will be in this category. Okay. So dyslipidemia, as we all know, it is either to be primary, coming from genetic factors, like all the familiar hypercholesterolemia subtypes, or it can be secondary. Secondary means there is another underlying cause that provoke or predispose dyslipidemia in this case, and this underlying cause can be coming from diet, drug, any disorders, or disease. Okay? So you can see here, maybe more important, what are the medications, the diet changes, and the disease state or medical conditions that can affect increasing LDL and increasing triglycerides. This one is very important. In screening of dyslipidemia, the medication history in general overall, and the accounting for the medical condition or the underlying medical condition is very important to give maybe overall picture. Also, as a pharmacist, we are more interested actually into medication wise. So when it comes to dyslipidemia also, it is very interesting to see how the medication can impact the different lipid parameters at different level. Same medication, it is not just maybe medication A, for example, have adverse effect on the lipid profile. We have actually to take maybe further step to look which parameter in the lipid panel will be affected by this medication. For example, the isotretinoin. Maybe some of us could be aware of the isotretinoin 1 treatment called eczema, and sometimes can maybe have so many dermatological application. The isotretinoin can affect the VLDL, increasing, can decrease the HDL, but doesn't have any impact on the LDL level. Maybe another example, for example, is very common, thiazide diuretics. Thiazide diuretics is very common example. We can see that thiazide diuretics compared to isotretinoin, thiazide, for example, can increase VLDL, increase LDL, and decrease HDL. So maybe understanding the intra-differences between medication when it comes how they affect the lipid panel is very important. So the most important part before going the treatment is this one, CVD risk assessment. When it comes to dyslipidemia, we didn't just treat levels. It is not just LDL more than maybe 2.64 or something. We have to give treatment. We have to understand the cardiovascular risk. And some of you, when it comes, maybe if you maybe going with maybe your parents, for example, to the clinic, when you see the screening for the dyslipidemia, we'll see on the sheet the levels, and the second part of the sheet, the cardiovascular risk, the stratification. And mostly the family health specialist will calculate based on the level, will calculate for the cardiovascular risk. It is low, the moderate, high, or very high. This one is very important. So patients usually, they have already cardiovascular disease, they have kind of chronic disease, they have diabetes already, This mainly will be in the very high, and in the best case scenario will be the high risk. Okay, very high and high risk. We'll see the categories later on. All other individuals will be stratified based on the equations. Quite number of equations are there. I think the most common and widely used, the Framingham General Cardiovascular Risk Score. If you just put in the link, you can calculate your risk maybe on a spot. Okay? Hopefully, inshallah, your risk will be very low. Still young, mashallah. The intensity of the risk factor reduction and target lipid levels will be dependent on the individual risk assessment. Meaning, based on the risk, we will decide how much we want to decrease in the level, how much we want to engage in certain intervention. This is very important. The next, the target, the normal level or the target level for different risk categories are different. For example, if patient at low risk, we target slightly higher LDL compared to patients at high risk. High risk means we have to go intense. We have to aim for lower LDL level. This is a concept in general. High risk means we have to go deep or lower when it comes to LDL level as a measure. Okay? Okay? So the risk stratification, as I mentioned, we have very high risk, those mainly established cardiovascular disease, diabetes, the chronic kidney disease, with some maybe major declining in the glomerular filtration rate. We have the high risk individuals, diabetic without any target organ damage yet. This is still high risk. So diabetes patients doesn't have any kind of maybe target organ damage now, still at high risk of cardiovascular disease. This is very, very important concept we'll discuss also later. Those with multiple risk factor. Here, when it comes to these two categories, the intermediate or low, will based on the calculations. Okay? We have to calculate a percentage. This percentage give us indication in 10 years the cardiovascular risk, how it will be look like. Okay? The cardiovascular risk in the next 10 years. So usually in the cases, brother and sister, I give you this percentage. So from this percentage, you have to understand which category this belongs. Right? Sometimes you get some feature from here, so you understand it is high risk or very high risk. Sometimes I give you number here, so you also get some idea about the risk stratification. Again, what is the importance of this risk stratification? What is the importance of this risk stratification? Exactly as you mentioned. Yes, it is this one. This will help us to plan which target level we are aiming to for every one of the lipid parameters or the lipid panels we are aiming to modify by our treatment. So what you can see, brother and sister, here, as we go further in the risk, the higher the risk, the lower the target level that we are aiming to achieve. Meaning, in patients with cardiovascular disease, they already have ischemic heart disease that we'll discuss, I think, maybe next week together. They already have ischemic heart disease. So the target or the normal level that we are aiming to achieve and maintain is something 1.8 or below. Okay? And if this patient is above this target or out of this target, so that doesn't mean, it does mean that some more intervention to be offered. Some more maybe planning how to further achieve this target to be there. High cardiovascular risk 2.6 and 3.4 in some cases when it comes to intermediate risk. In general, the concept, the lower the LDL, the lower the risk. This very important concept in dyslipidemia pharmacotherapy. The lower, the better. The lower, the better. The lower LDL, the better will be the outcome. Okay? So, for example, if these patients maintain 1.8, will not be harmful. This means it's better for him maybe compared to higher level. Okay. Can we take this one, please? Which best describes a potential secondary cause for high triglyceride concentrations? Hopefully, many will be at the same time, right? Don't wait until to see the answer, please. The question is clear, right? Secondary cause. You remember the secondary causes of dyslipidemia? Drugs, diet, disease, disorders. This one will be amiodarone, the pili obstruction, the sirolimus, or the saturated fats. Yes, faster, faster, brother and sister. Hopefully those maybe looking at the screen, they already answer, right? Or still in the brainstorming, looking for the answer. Okay. We see maybe a very close racing between amiodarone and saturated fat. We're still accepting responses, brother and sister. Please come in, especially brother and sister on MS team. Okay. At the interest of the time, I will proceed. Thank you so much. I think about 52 already maybe come in and participate. The answer? MashaAllah. So we're still so sleepy, right? So sleepy. So this one, I think maybe it needs some focus from your side. In the secondary courses, I believe maybe the time we discussed this one is not enough for you to comprehend all the medication. But just I want to mention that quite number of medication are there, quite number of conditions are there, and the impact on both the LDL and triglycerides also have to be compared properly between both. Okay? Thank you for the 3% who answer correct. Thank you so much. So that outcome, of course, we aim to achieve maybe the LDL level, but one major feature, the more we decrease, the more it is better. So for every parameter, we have borderline high and high, And some parameter actually can be divided even to further categories based on how far we are from the target level or how we are so close or within the normal target level. The dyslipidemia, as I mentioned, it is not treating levels only. The ultimate goal of us that we want to achieve is to prevent the atherosclerotic cardiovascular disease. So we can see maybe this level is a step toward preventing the atherosclerotic cardiovascular disease. This is the most important. And usually we have quite a number of medication, but the focus will be given to those medication. The clinical trials or the clinical evidence is very strong for this particular medication. Cardiovascular, as I mentioned, the desired outcome or the ultimate goal is what? Cardiovascular disease prevention. This is the ultimate goal. With this one, actually, as a treatment only, if you give dyslipidemia, but the patients maybe engage in unhealthy diets and he's smoker and physical inactivity and all this will not help much. So actually, the pharmacotherapy will be part of behaviors, lifestyle modifications, interventions. That all of these interventions are aiming to help the patients for better cardiovascular health. You can see here the LDL level. What we are targeting here is just one of maybe the measures that can be taken in a given case. Therapeutic lifestyle changes. Just to maybe have a look here if you want maybe more data on how much the dietary fiber, the weight reduction recommended for based on gender, the exercise in range recommended for those patients. Smoking, of course, recommended to stop smoking. This one already may be discussed in pharmacology, but from therapeutic points of view, we want to highlight two aspects. Yeah, the first one, the impact of every class on the LDL level, the reduction. Because as we discussed in the very beginning, when we choose the treatment, and sometimes when we choose how much of the treatment to be given, will be based on how much we want the reduction to be looking like. We want to reduction, for example, 20%, 50%, more than 50%. This one have to be in the planning of the pharmacotherapy very clear. So understanding the differences between different classes, how it affects, how it looks likely will decrease the LDL level. For example, we have the statin, very common, one of the most common medication used globally. It is not in Malaysia. I think it ranked number 4 or 5 in the National Malaysian Statistics of Medicine utilization over years. This very common one. So this one you can see the LDL, for example, can reduce or induce reduction between 20 to 55, okay, based on the intensity. The fibric acid derivatives, the fibrates, maybe around 20 to 35. We have the group new injection and slightly expensive group of medication, the protein convertase subtyrosine kissing type 9, as an abbreviation PCSK9 inhibitors. This one can provoke up to 70 something of the reduction in the LDL, but of course it's challenging. This may be weekly injection and all this stuff. The side effect, I think, maybe we have more on this one discussed in the pharmacology already, but of interest for the statin, the muscle-related symptoms, myopathy, sometimes myositis, in rare cases, rhabdomyolysis, the transaminases or increased liver enzyme, and some reports on new onset diabetes in certain cases. We have dyspepsia and myopathy also with fibrates. When it comes to the injectable medication, the injection site reaction, sometimes the limb pain, the nasopharyngitis is actually very common. Very common doesn't mean it is not well tolerated, because when it comes to the statin in terms of tolerability is a very well tolerated medication. Usually very few of patients can develop distressing symptoms or intolerable side effects that prevent them from keeping with the medication. Okay? We have some here of the contraindication when it comes maybe statin. Of course, the liver disease, the patients who have or currently in acute hepatitis, for example, or acute liver disease, or having maybe very high transaminitis liver enzymes are very high. This, of course, not the ideal case to give statin as well. And the statin, the problem, as I mentioned, is widely used. So we know more about the drug-drug interaction. Quite number of medication can interact with statin. So maybe screening for all the medication in patients taking statin, especially dyslipidemia, usually will giving to those patients relatively high age, right? Relatively high age, and relatively they have underlying condition. So by right, as a baseline, they have quite number of medication with statin. It is not common to get statin alone. Quite number of medication will be there. So it is very, very important also to understand. We have the bile acid sequestrant, the PSA. PSA is one of the effective group as well. But we can see here in terms of how the potency in decreasing the LDL level is not that much. It can maybe give us maybe up to 25, like maybe the niacin. And you can see here also the cholesterol absorption inhibitor, the ezetimibe, the same. So from our understanding here, that this group of medication most likely will be as add-on or combination if it will be used. But it is very rare to see patients dyslipidemia at high risk, for example, and taking monotherapy of this medication. You understand the point? So most likely the monotherapy will be based on Mm. Okay, MS team, they will take time. Why you take time to answer? Will be so the monotherapy of dyslipidemia will be mainly through which class of agent? Okay, I see very statin. Yes, statin. Yes. Okay. We'll see in details, but I just want you from this table to understand the differences in how likely they will decrease the LDL level, because this one will help us to understand why the recommendation looks like. You can see here why statin is everywhere. So now, hopefully, you get some understanding. What are the basis for us to see statin, for example, as a monotherapy for patients with very high risk and high risk categories, and also in intermediate and low risk categories. So statin is maybe the most recommended level, high level of grade of recommendation, the high level of evidence. Means the quality evidence, so many evidence giving us the same indication, and maybe supporting the same the clinical recommendation. Of course. What else? If the statin alone is not maybe that satisfactory for us, we can think about add-on. Again, you can see here, add-on. We didn't take off the statin. So the statin is very, very important and very well-established treatment, actually. Very effective as well. So if the patient tolerate by somehow, we'll not take it out, okay? But we can think about what it will be the next step. So the next step sometimes will be the ezetimibe. Sometimes if the patient failed to achieve the LDL goals, very well tolerated, and if combined with the statin, will increase the LDL reduction, at the same time will confer additional benefit. PCSK9 inhibitor, but this one actually it is not the second step, because this one is a bit expensive, and this one actually maybe in terms of recommendation as a combination therapy should comes after the ezetimibe. Ezetimibe more cost effective, and if the statin is given as a high intensity, PCSK9 will not maybe having significant add-on effect on the LDL reduction compared to the statin. In overall, they have more, but I mean about the combination, because the statin give us up to 55, right? This one give us up to 70%. This one will add, when added to the statin, will add around 18%. Okay? This is actually the number we discussed in the last slide. It looks like something new, right? So the order here is meaningful. So the first combination will be this one. The second will be this one. PCSK9 actually, by the way, it is first indicated for familiar hypercholesterolemia. Then later on, they expand the indication to be offered for patients with maybe dyslipidemia in general. Familiar hypercholesterolemia, the one with genetics root, the one we highlight in the beginning. Statin and fibrates sometimes can be used in patients with diabetes on maximally tolerated statin, have achieved the LDL level, but still struggling with high triglycerides and low HDL. In this case, fibrates can be used. Ezetimibe alone, when it comes to non-statin therapy, we are very specific about cases of statin intolerance. I will discuss the last point in the lecture. Statin intolerance means those patients we tried by every way for them to be maintained or to be given statin, but for some reason or another, they cannot. They cannot tolerate statin anymore. PCSK9 in some patients with statin intolerance at very high risk, fibrates, very high triglycerides, despite any therapeutic lifestyle changes. This table is very important. Combination therapy, as I mentioned, we have statin ezetimibe is the best. We have also statin and bile acid sequestrant sometimes can be used. Statin PCSK9 inhibitor also can be used. If patients low HDL and high triglycerides, as I mentioned, in this case, we can think about the fibrates to be added on in this case. Add on to help us to achieve the target, but whether it is correlated or it will result in reduction in the cardiovascular events, this one, it is uncertain. It is not like the statin. When using a combination statin and fibrates, we have to be very careful which fibrate to be used. Okay? We have as a combination with statin. For example, if gemfibrozil will be the risk of myopathy will be much, much high. And the patient's risk to develop muscle symptoms will be very high. So it is not recommended to give gemfibrozil with a statin. Gemfibrozil can be taken maybe as a monotherapy in patients who have a statin intolerance or no longer need statin and for triglycerides. In this case, maybe this combination, as I mentioned, is discouraged, and the fenofibrate to be used in some cases. The fenofibrate to be used. I think this one you should be aware. When we talk about statin, we talk about reduction from 20 to 55. So based on what? Based on the dose. In the dose, when it comes to dose of statin, we have intensity classification. So we have this low intensity statin, moderate intensity statin, and high intensity statin. Low, moderate, high, based on the percentage of reduction they can give us in a prescription on a given case. For example, at the range of reduction of the LDL level by less than 30%, we categorize all this as low intensity statin. If between 30 and less than maybe 50%, so we have the moderate intensity statin. If it exceeds 50%, so we are in the category of high intensity statin. So in a given case, for example, we can say high intensity statin or low intensity statin or moderate intensity statin, and you understand. Or the other way around, we can give you maybe one of this regimen, and you understand to which category it belongs. Okay, it can come the either ways. Okay. Very important point. When we double the dose of statin, it is not much correlated with the reduction of the LDL level. This is very important concept to be in your mind. For example, if you give statin maybe 20%, okay? For example, this one. Simvastatin, 20%, 20% for example, right? And then the simvastatin 20, you change to 40%, right? You are expecting maybe doubling the reduction in LDL level. Actually, it is not that the case. It is not that the case. The reduction in the LDL, it is not that correlated with the doubling the dose of the statin. So much more important, you can see here simvastatin from 20 to 40, the reduction just maybe 5%, something like this, 5%. And that's why both of them are categorized under the moderate intensity statin. It is no different class, right? If it is already doubling, you can see one in the moderate intensity statin, the other one in the high intensity statin. It is not like this. Okay? So this concept of understanding the differences between different statin is very important. Okay? Okay? Okay. So this overall recommendation from the European maybe Society of Cardiology, the latest guidelines, this the same like the Malaysian guidelines I showed you earlier. But if you want maybe to have it maybe in a written format, you can see here it is recommended to give high intensity statin for at the highest tolerated level, the dose, to reach the goal set according to a specific level of risk. Specific level of risk. The goals are not achieved within the maximum tolerated statin, combination therapy to be there. Which one to combine? The ezetimibe. The primary prevention. What is the difference between primary and secondary prevention, brother and sister? Primary prevention means we want to prevent the cardiovascular disease from happening, but the patient has not yet developed any cardiovascular disease. He is at risk, but has no history of cardiovascular disease. So we want to primary prevent, like maybe patient with diabetes, but he doesn't have any cardiovascular disease yet. So this patient at risk, but no risk has no disease has been developed yet. The other case, patient with diabetes, develop maybe have one incidence of heart attack, for example, and now after the heart attack, we want to prevent a further attack, the second one. So this secondary prevention means we want to prevent further events that already one of them or two, for example, happened already. So primary prevention, you can see here the statin and some statin ezetimibe or PCSK9 to be there. Familial hypercholesterolemia, that's the same. You can see here statin ezetimibe or combination PCSK9. So it is same like the table I showed you earlier on. Algorithm based on the patient group. This one should summarize all. It is not something new, but should summarize all from your side. How the primary prevention, this patient doesn't have any cardiovascular disease yet. They are at risk. So based on the risk, we decide which intervention to be given. It is low risk. So just lifestyle modification, ask them maybe to engage more in exercise or something like this. Or a borderline risk. So in this case, we have maybe to consider moderate intensity statin, to consider intermediate risk within this range, 7.5 to 19.9. Say moderate intensity statin should be given, at least moderate intensity statin should be given, or high risk, high intensity statin. This in which patient group, brother and sister? Which patient group, this one? Hello? The primary prevention, right? The primary prevention group. This one, the patient group. This one, the category. And this one, the intervention. Okay? Sleepy. Okay, patient with atherosclerotic cardiovascular disease is a patient group, right? Here, very high risk or not very high risk. You can see here, all of them will take statin, at least moderate intensity statin in those patients relatively older. But the rest, high intensity statin. Means next week when we discuss about ischemic heart disease and patients has to be on the statin, in this category we mean high intensity statin. Okay, straightforward. Severe hypercholesterolemia, the levels is already abnormal. This one maybe the maximal tolerated statin should be there. Patient with DM, very important. Patient with DM, based on the age group, but usually type 2 diabetes, maybe 40 and above, will be in the category receiving at least moderate intensity statin, and some of them will have high intensity statin. Okay? Okay. One more point to go to understand the clinical benefits, how the correlation between the lowering or the medication that has been given and how it contributes to the absolute reduction later on in the risk of cardiovascular disease. So basically, brothers and sisters, when we give therapy, we give therapy to induce or to achieve reduction in the LDL level, right? This is our main aim. And this reduction should be translated according to the baseline risk to give us some calculations regarding the absolute reduction in the LDL level. This, for this case, the absolute reduction. The absolute reduction in the LDL, this one quite correlated or associated with 20% reduction in cardiovascular events. This actually slides for you just to understand how it relates. If you decrease the level in a given case, this will contribute to assessment or decreasing the absolute reduction in the LDL. This one is quite related to the cardiovascular events and help us to make or to achieve the absolute reduction in cardiovascular events that the clinical trials show us. When you're using maybe, for example, in one trial, for example, using a statin for 5 years and above, the group, if you're using a statin, 20 or 30% of them doesn't develop the cardiovascular event compared to the other group, for example. So this one, the actual evidence that show us how maybe decreasing LDL will be beneficial in a given case. Can you take this one, brother and sister, very quickly? This quite maybe similar number of cases that we can see later in the assessment, in the exam, in the cases. So in this case, the 58-year-old man has no underlying cardiovascular disease. What do you understand from this one? Increase the volume, brother and sister. Primary version, okay. So the lipid panel, total cholesterol, LDL, triglycerides, or the 10 cardiovascular risk of 14.6, which would be the best therapy? Okay, okay. Okay, just maybe at the interest of the time, I can see, before any changes happen, I can see many of you going to the correct answer. The atorvastatin, actually based on, we have to give moderate intensity statin. The other choices, either the combination is not recommended, like the first one, the gemfibrozil statin, as we discussed, the combination increase the risk of myopathy, right? The second one, fluvastatin 40 milligram daily, this low intensity statin, and this patient, according to the risk, we have to offer moderate intensity statin. Bravastatin and fenofibrate, bravastatin is still low intensity statin, and fenofibrate doesn't add much in this case. So we want moderate intensity statin. In this case, we have atorvastatin, right? Clear? Alhamdulillah. So maybe last section, and we cover very quickly the recommendation based on all this. The recommendation, the lipid profile should be measured at least 1 or 3 months following the initiation. The dose should be adjusted according to the measured level. In safety measures, the hepatic transaminases should be assessed baseline at 1 or 3 months later on. The creatinine kinase will be measured if myositis is suspected, not actually a routine. If there any adverse effect, this kind of reduction and sometimes temporary discontinuation can help. We'll discuss a little bit maybe in the statin intolerance that we can reintroduce even the same or different statin at a lower dose as a second attempt. If the symptoms are still there, we cannot do anything, so we have to look for alternative and discontinue the treatment. Primary prevention, as I mentioned, maintaining healthy lifestyle is the main. Screening for all individuals at risk 30 and above by getting the full lipid profile is very important. Individuals at high risk should be investigated maybe even earlier. Secondary prevention, those with cardiovascular disease we'll discuss later on, maybe next week when it comes to ischemic heart disease. Those usually will giving high intensity statin all the way around according to their risk. On admission and prior to PCI and later on will be considered in all individuals with any previous ischemic history, ischemic stroke, ischemic events, myocardial infarction, all this will be considered. And specific population, when it comes to hypertension is very common in patients with diabetes, but we didn't give a statin for hypertension. But usually hypertensive patient will be at high risk if they also diabetic, so statin is very important for them. Diabetic patients will receive a statin regardless LDL level because they are at high cardiovascular risk. This is a very important concept, brother and sister. We didn't give statin in diabetes just because they have abnormal lipid. No. Being diabetic patients 40 and above, you're already at high risk for cardiovascular disease. So you deserve to be given statin. Heart failure, if ischemic origin can, but if non-ischemic origin, for example, dilated cardiomyopathy or something like this, it is not the exact indication for statin. Renal disease is very important, but if patients coming to dialysis, it is not recommended to give statin for primary prevention. If already on a statin and maybe now on dialysis, just continue, no problem. Specific group, we aim for the both, maybe in both genders and elderly, the same levels. There is maybe no different in the level. But when prescribed lipid-lowering therapy in elderly, we have to make sure take care of the comorbidities and the altered pharmacokinetics should be there. That's why in one of the algorithms I show you in relatively older, more than 75, they get moderate intensity, not high intensity. Should be used in a lower dose and then titrated with caution. Children whose lipid levels are abnormal will be receiving special care. Most likely they have genetic dyslipidemia, the first. Issues with lipid-lowering therapy, I will maybe, perhaps you can read maybe this one later on. This, for our understanding, we have issues of under-prescribing, discontinuation rate, statin intolerance, and non-adherence. All of them may have special measures to be done. Statin intolerance, the prevalence could be very different from observational to RCTs, but where the patients cannot tolerate statin. In this case, actually, you have some of the risk factors. There can be some of the risk factors we can maybe intervene, the modifiable one, or some will be intrinsic one. This kind of maybe common medication that interact with statin and can help with statin intolerance to develop. And this, some of the recommendation for statin intolerance, like maybe getting some behavioral measures to be implemented, statin-based strategies, maybe discontinuation or alternative scheduling or intermittent dosing, non-statin therapy as we discussed already in the lecture, and some of the treatment that have been tried to relieve the muscle symptoms, but no major effects. And this may be our understanding, the adherence from patients, physician, and healthcare system should be all implemented collectively. Okay? I think that's all for me. Thank you so much. And if you need, maybe at the end of the time, if you have any questions, just let me know, inshallah. You can maybe communicate in